Okay, welcome to the audit on headache red flags. Red head, we're calling it, or head red, probably. So the objective of this audit is twofold. So are we both asking headache red flags and are we acting on them? And we've actually found them, interestingly enough. The methodology, really simple here, is the sample size was 80 EMIS, and the criteria was the International Headache Society, NICE, and the American Headache Society. Oh, I'm back. That's nice, isn't it? The results overview. I'm just moving to one side here. So there's a bit of space. Percentage of consults who documented red flags of any sort were 54%. So they'd actually documented something. Okay. The percentage of doctors who asked every single red flag was 4%. Have you asked at least one red flag? Okay, so one thing that could be construed as a red flag that you've indirectly or directly mentioned. So maybe you've done a fundoscopy and there's no papilledema, but you've not mentioned red flags specifically. That's 75%. So just by doing our normal medical model, we're finding at least that we are covering at least one red flag in 75% of cases, which is useful. What percentage of doctors in 80 consults with headache and primary care found a red flag? 0%. Is that to be expected? The answer is yes, because 1% of headaches in primary care are secondary headaches, and even the vast majority in headache clinic are primary headaches. So it's to be expected that it's going to be low yield. Is it that low? And have we asked enough to be convinced of that? I'll leave that to you to decide. I'm moving over again now. The details of the results are percentage seen by a doctor. 100% was seen by a doctor. Percentage given a headache diary, 5%. And the percentage documented conservative advice, 20%. Now, I would venture for a 100% hit rate of doctors, that leaves something to be desired, doesn't it? So, of all 80 patients, no red flags were positively found. So there were no inappropriate or misreferrals based solely on this data. So what were the discussion of key findings here? Okay, so I put, let's just review SNOOP. So we've got systemic features, neurology that's focal, onset of a thunderclap or over 50, and precipitation with exertion or papilledema. There are others. Evans in 1990 coined SNOOP, and all of the societies basically use SNOOP as the basis. There is like SNOOP 10 now, where there's like loads of P's, but these are probably the most important ones and the ones that we are most likely to assess. So I've just put here the tables with some sensitivity and specificities. They're all pretty good. Pretty darn good, I would say, for a pretest probability thing. If you've got systemic features with a headache, you need to work it up as if it's meningoencephalitis until proven otherwise. If they have focal neurology, it's a non-contrast brain, same with thunderclap. Over 50, it's MRI, and precipitation of exertion, or PAP, it's an MRI. Now, systemic features, to me, that's an interesting one because it's quite high sensitivity, but specificity is it's one of the lowest. Obviously, if someone comes in with a cold and a fever from the cold and a headache from dehydration, are you going to send them in an ambulance with BenPen? No. So this is where it's a heuristic, right? If a headache is SNOOP positive, even one, you cannot watch and wait or diagnose a primary headache. They require AED or urgent imaging. That's what the societies tell us, that one SNOOP is enough to send. Okay, so SNOOP has to be sought and acted upon. And so I recommend a quick code of SNOOP to prompt and help. So hashtag SNOOP could be put into EMIS, tapping away, and replaced with this, which is the negative. So you can use it as an aid memoir. You can delete before you press save. So the conclusions here are that we're not doing red flag assessment, documentation, conservative management, or a headache diary sufficiently for our patients. The limitations are patient number, and we only did it for a week. So I think the next step is a leaflet to each clinician with the findings, table of sensitivity and specificity, and next steps. and a hashtag Snoop quit code for the practice and re-audit it in 2 weeks. So that is my audit. Thank you very much.